Thank you, Allison. I appreciate it. And all of the help Cognitive Care Solutions has given my patients on multiple fronts. So we're lucky to have your organization serving Orange County, and a large percentage of my patients have been able to take advantage of the care. So I saw a lot of familiar faces when I briefly saw pictures showing up on the internet, or sorry, on our screen here. So I'm looking forward to giving everybody a little bit of an overview. And my team and I just came back from the Movement Disorder Society's big talk out in Pennsylvania, in Pittsburgh. And so I have a lot of interesting information to give those. So this is not so much kind of like the basic course on what is Parkinson's, but more like, okay, everyone has a little bit basic understanding of this dopamine deficiency in your brain. Here's your brain. And the dopamine deficiency is occurring right here in the top of the brainstem. And once that occurs, we start having the symptoms of Parkinson's, of stiffness, slowness, frequently resting tremor, and a multitude of other both motor and non-motor symptoms involving walking and shuffling of gait and falls that can occur, as well as other effects on blood pressure, causing it to go down, and eventually some slowing of cognition, which is why I partner with Allison in terms of connecting you with her services when needed. And Allison just reminded me that, Cognitive Care Solutions isn't just for the patient, but can also be helpful for caregivers and loved ones who have been impacted. Oftentimes, I use the analogy of, our phones, and oftentimes the caregivers aren't being affected by the disease, and so there's nothing wrong with their brain, with their phone, but they're oftentimes being forced to multitask and do too many things simultaneously. When that starts happening, that's when we all start having a lot of difficulties with memory and focus. And it's this multitasking that we get demanded of in stressful situations and the modern situation. And much like our phone, when we open too many programs on our phone, the phone can slow down and you get lag. And so that particular phenomenon is one of the things that Allison makes such a big difference in helping recognize it, and then working and customizing in your individual situation on how to streamline things in your life to, decrease some of these distractors. And I've seen that help both the patients and the loved ones as we're coping with Parkinson's. So in terms of the new advances in Parkinson's, little reminder, and I've got a little picture here. Oftentimes we talk about the chemical deficiencies that happen in Parkinson's, and dopamine is always the big neurotransmitter that we talk about, and its levels tend to be low. And most of the time, a lot of what we focus on is replacing that level of dopamine using a medicine called levodopa, or maybe you know it better as carbidopa-levodopa or Sinemet. And so this is really the biggie in terms of helping people be more mobile, active, and functional. It tends to decrease tremor, improve walking, and improve our ability to exercise, drive a car, and get dressed in the morning, and have decreased falls. And so optimizing that is usually our first priority. But I always like to also mention that other neurotransmitters exist, such as norepinephrine and serotonin. And those can cause symptoms such as attention problems, slowing of the thinking, anxiety, depression, and balance issues. And then eventually, sometimes people in Parkinson's can also have a decrease in acetylcholine, and sometimes we can get true memory issues. So I like to use this little handout when I'm describing it, just to give people the idea that Parkinson's is more than just one neurotransmitter that we're replacing, but much like vitamin deficiencies, our job as the neurology team is really trying to listen to you and observe on your physical exam. And we're trying to figure out, all right, what are people describing to us? Which deficiency seems to be impacting you at a given time? And so again, focusing on that blue one, the dopamine level, the good news is, as you just literally within the last week or two, newer agents for longer acting carbidopa-levodopa to help people feel on and active. This is the medicine that's kind of like, if you feel like the Tin Man and the Wizard of Oz and you feel rusted and you can't move and it's hard to get started, it's hard to get out of a chair, out of a car, and get going, though that's when carbidopa, levodopa, and some of the long-acting agents, historically, for about the last 8 to 10 years, we've had Rytary. And that's been a really great medication. And we just had an inheritor to the mantle of the best version of carbidopa, levodopa, and that's this new long-acting version of it called Crexont. The big advantage to these long-acting agents is they help decrease the number of times people have to take the medicine during the daytime, and it improves on time. So on time, for those who've experienced Parkinson's, they know that the med levels can vary. You take a pill, the level goes up and you feel mobile, and then the pill goes off and you start feeling stiff and rigid again. Usually that can start within the first 3 to 5 years of us using levodopa. And so these long-acting agents really dramatically decrease this off time while simplifying your regimen. And I'm all about simplicity and making your life easier. And so these agents, instead of like having to dose a medicine, when I started, it's usually carbidopa, levodopa 3 times a day. And then over time, it starts to wear off earlier as the stomach and the intestine don't absorb it as well or as consistently. And then I have to go to 4 times a day, and then sometimes 5 times a day. Or I've inherited some patients from other providers. Sometimes they're dosing it like we would in the 1960s and 1970s, which is like dosing it like 6 or 7 times a day. And that's really tough on you and your family. So that's when these longer acting agents like Crexont can really keep the regimen simpler, right? We can keep the regimen preferably to 3 times a day for as long as possible. I have a few people who can get away with twice a day, and I have a few people who can get away with 4 times a day. But the majority of the time, if I can keep the dosing relatively consistent and not interfering with your meal times, that's really where the advantage of these new long-acting agents. I showed you that agent because, in my opinion, for all of you out there, when you're looking at open enrollment and you're picking your Medicare Advantage plans or whatever Medicare supplemental plan you enroll in, when you look at the formulary, there's, I really want you to look for at least these agents. I mentioned the new Crexont, but that may not be on some of the formularies yet, or at least it's the progenitor of it, which was Rytary. And so preferably having at least one of those 2 on your formulary makes your life and your physician's life easier in order to improve simplicity of the dosing and better on time. And while I'm mentioning it, this is the only other name brand agent I really need on people's formulary. And it's one called GoCovery. So this is a medicine that also is as old as carbidopa, levodopa. So this medicine is a long-acting medicine called amantadine. Amantadine was invented long, long ago in like the 50s and 60s for anti-influenza properties. But we have used it in Parkinson's, and it's been approved for Parkinson's since 1963, the same year that Sinemet, carbidopa, levodopa came out. And this medicine is a long-acting version of amantadine. It specifically helps with refractory tremor, balance problems, and Michael J. Fox's problem called dyskinesia, when people have this excess movement when their dopamine levels are a little too high, and GoCovery is the most effective agent at blocking that. So I always like folks at this time of the year, when you're picking your plans, those 3 agents, Crexont, Rytary, and GoCovery, should really be at the top of your list, and trying to get one or more of them on sort of what your insurance would cover, just to make your life and your physician's life easier when complications occur. These are quite easy solutions, and all they are is just long-acting versions of the gold standards that we've used for 60 years. Right, actually 61 years this year. So 1963 is when these agents came out, and they revolutionized the treatment of this disease, but we're coming out with better variants. And really, it's all about obtaining good GI absorption and consistency at entering it, because that's really where most of the medicines don't stop working for people. That's a myth. That's a myth from the 1960s and 70s. And so but optimizing how well they get absorbed by your gut, because your intestine becomes lousy at absorbing some of these medicines over time. But if we can get them into you and get them into your bloodstream, they will get to your brain and they will continue to help for the duration of your life. And we've proven that now and kind of broken that myth about it. So good. All right, good. I can let you know that. And since I'm on the topic of carbidopa, levodopa, how do we get that to work as good as possible? We have, some people, we have to kind of microdose. Not a lot of people, but every once in a while I need people who they just need a little bit. They need an extra quarter pill or half a pill or 3/4 of a pill. And it's very difficult in Parkinson's sometimes to cut pills and optimize the dosing when we just need to do that fine tuning. There is a solution for that. This is actually a reasonably cost-effective solution. And all it is, Divi, is just it's carbidopa, levodopa, immediate release. It's not long acting, but it's easy to break. You can break it easy into half tablets, quarter tablets, 3/4 of a tablet. And so this particular version is really good when your doctor and you and your family need to be able to fine tune the dose. And you just need a little goes a long way. You just need a little bit extra. This is a great, easy way that works with your ability to coordinate breaking these things. And you don't need a pill cutter. You can even do it with your own fingers. And so that's been a nice way to optimize things. And that one's not particularly expensive. Okay, so other big improvements that I wanted to let you know about really involves delivery of the medicine. All of the things I've shown you so far are currently available. We have a good track record with it, but they're all really oral versions of the medication, all great. But when we talk about advancements, there are other ways to deliver carbidopa, levodopa, and these are new. One of them, which is really more appropriate, for advanced cases, is using a PEG tube, a tube that can go into the stomach and deliver the medicine directly into the intestine using a tube that can deliver that medicine, and it winds its way into the intestine and can deliver that medicine all the way into the intestine and get really consistent absorption. Great option for later in the disease, not one of my early options, but it's been really helpful at getting it when people's absorption of the medicine has been really inconsistent. Okay, we've had that for about probably closer to 10 plus years. Good effectiveness. However, not everybody is, amenable to that. So what's about to hit the market in probably the next 6 to 12 months, we wish we had it already, is they are coming out with subcutaneous pumps. So if you've ever heard of an insulin pump, right, there are devices that are outside of our body that can deliver medicines under the skin for consistent delivery and absorption. And we've been working, more than a decade on technology that could do that with carbidopa, levodopa, to try to, again, get really consistent levels in the blood to not let you fluctuate on and off throughout the day. So that technology is here. The FDA has delayed its release on our market. We're hoping that they'll finally get the final approval going. It's already been approved in the European markets, so for more than a year, almost 2 years. And the reports from the European markets have been exceptionally good. So that's really then sort of a wearable device, kind of like a pager that you'd kind of wear on your belt. And you would connect it under the skin, and it would deliver the medicine under the skin continuously for the duration of the day. No pills involved. Great choice when you're having a problem swallowing pills, or great choice when people have complicated regimens. The only downside is it does involve placement of a little tiny needle each day that they make it really easy. It's sort of stuck on with a patch, and the delivery goes really well, and it seems to be really well tolerated. But really the one side effect that sometimes occurs, sometimes we'll get a little bit of scar tissue or granulation tissue right near the site that we're using. And so oftentimes it helps to move the sites around on your arm or wherever it's delivered. So we'll be able to give you more information about that as the FDA approves it. This is me just giving all of you insight that that's a really great option when you're struggling with the pills. Obviously, we all think pills are usually easy and most people tolerate them well, but this subcutaneous pump for carbidopa levodopa would really be good for, again, complex cases, people like Michael J. Fox, that their meds are really fluctuating. If the meds aren't getting absorbed well, if you have some other kind of GI pre-existing problem where it's really interfering with your absorption, and we need another route of delivery. Okay, so that's really a really positive thing to look forward to in this. We have other routes of delivery, a little trickier to get a hold of, but there are even inhaled versions of carbidopa levodopa, like an inhaler, and it's a powder, and we do little breaths in to sort of absorb it, and that can really kick in quite quickly. And it really, my patients have usually seen when they go off really abruptly, this Inbrija inhaler, let me show it again, that's how you spell it, Inbrija, it kicks in quickly and relieves an off time quite fast. Little trickier to get a hold of. Oftentimes the movement disorder specialists are going to be a little bit more able to get it than the average doctor. Even we have sometimes struggles, but it's been probably one of my most consistent and well-tolerated agents. Just needs a little bit of guidance on how to use it as an inhaler appropriately. That's all. Okay. And it wouldn't be something people would necessarily use every day, but it's a great rescue medicine if suddenly your meds wear off and you get really stiff and immobile. You're at a movie and you can't get out of the chair, or you're at an event and you suddenly go off and your meds are taking too long to kick in because your intestines are taking too long to absorb it. So again, Inbrija is just carbidopa levodopa, and it's an inhaled version. Okay. So those are some good options in order to kind of get the dopamine levels up, right? Going back to my picture, trying to get that low dopamine level to be up, and then it varies throughout the day. So we want to try to keep it up and try to keep it reasonably consistent so that it doesn't drop too low. Okay. Now, so there are other tricks that we have out there. I'm always full of tricks. Anytime you come into a movement disorder specialist, we always have lots of tricks up our sleeve. And some of those involve, increasing how long the carbidopa levodopa lasts. And a medicine that's once a day, like Ongentys, can even if you're taking the pills, can help keep the carbidopa levodopa, especially the levodopa and dopamine levels, even and not let them drop or fluctuate as often. So that's been a good once a day solution. This is related to one that a lot of you may be taking called entacapone, also known as Comtan, or the ingredient that's in Stalevo. It's another older version of it. So Ongentys just ends up being pretty simple and it's long acting, and it's just a single pill. So I like it because it tends to be reasonably gentle. It's simple. It doesn't add a lot of pill burden. Trust me, at least at the movement disorder centers, I always think twice before adding another pill. I try to look at how do I keep the regimen simpler and as streamlined as possible. But when you need it, when I have to replace one of the neurotransmitters or I have to optimize the dopamine, I need to pull these different treatments in. I wish I could always treat the disease with one type of medicine all the time throughout the 20 plus years you're going to have it. But the reality is we need these options, and we're lucky we work in this era where we can deliver that and customize it to each individual patient. Okay, so those are the big ones I wanted to talk about on the medication end of things at the moment. But I did dabble a little bit on the surgical end. In Parkinson's and tremor disorders, there are oftentimes both non-surgical and surgical options that can be used as well. One of them is something that I've got a lot of folks asking me about, has been something called MR-guided ultrasound, also known as focused ultrasound. So that particular surgery. And it's not an invasive surgery, right? The patient essentially, we're trying to target in the brain and use ultrasound to cause a little burn lesion, like right where that dot is in the brain, using the ultrasound. We're trying to heat up the brain in that location and damage the tissue to relieve tremor and Parkinson symptoms. So it uses a special machine that the neurosurgeon kind of put you into, and they have ultrasound emitters aiming in lots of different directions. And where they focus it is where the part of the brain heats up. You're not in an OR, it's an outpatient procedure. There is a device currently up at Orange Coast Memorial, and I believe there is already one now at Hoag, and there will be one. I don't think there's one at UC Irvine yet, but those are at least the two centers I know for certain are up and operational in Orange County. So again, the surgery reminds us a little bit of the old surgery that Michael J. Fox had. Michael J. Fox had a surgery where they put probes in the brain and did a little burn lesion in that part of the brain. And at the tip of the electrode, or the tip of the probe, they heated up the probe to damage that part of the brain. Now we do that same procedure, but externally without a probe going through the brain, and it heats up and causes that same lesion in the brain. When do we use it? It's not my first choice in most cases. It's really good for patients who are a little bit more frail, a little older, folks who only have symptoms really on one side of their body. If they're fighting a lot of other medical conditions like cancer, or they have a lot of cardiopulmonary types of problems that really make them poor candidates for other types of surgery. Really, because once we lesion it, people can get good help. But remember, the disease can progress. And so a year later, 3 years later, 5 years later, there will be some symptom reemergence as time goes on for patients. And there's no current clinical data or approval to re-lesion it, right? Michael J. Fox went in for multiple surgeries to burn that part of the brain, but in the focused ultrasound or MR-guided ultrasounds case, we don't have data to be able to go back in. So the insurances wouldn't really cover that at the moment. Could it be helpful? It could be, but I wanted everybody to know it's like you get one chance at it that the surgeon does, and they'll get you whatever benefit they can. It's most effective for tremor, oftentimes on one side of the body or the other, but they can't always do it bilaterally. They can't always do it on both sides of the body. And remember, Parkinson's and other tremor disorders usually affect both sides of the body. So again, it's a good tool. Should it be used for every Parkinson's patient? No, but I feel like there's a definite subgroup of folks that we talk about it. We talk about it as an option, and it's nice because recovery is quick and it's non-invasive, and we get results, really rapidly from it, either that same day or in the next few days afterwards. But use caution and talk with your movement disorder specialist about that. General neurologists will not usually manage those cases as often. Okay. So what's the other alternative? We've talked about it before. And so if we want the ability to modulate the firing as the tremor progresses, or as the stiffness and slowness progresses, and keeping up with the Parkinson's disease, then we're really looking at devices like these. So these are something called deep brain stimulation, and these are two of the manufacturers, Medtronic and Abbott, and I have a third manufacturer, and called Boston Scientific. Here we go. So all are really good options. And these are little pacemaker devices that go under the skin of your chest, right below your collarbone. And for women, sometimes the surgeon will move it a little bit like closer to the underarm, so it doesn't fall within a scoop neck shirt. And so these devices have been absolutely game-changing and revolutionary, and are something I've been able to adjust with patients over the years that they've had this implanted. this deep brain stimulation is a neurosurgery where the surgeon puts in leads, wires, deep into the brain to where the symptoms of the Parkinson's are occurring. Essentially, a simple way to think about it is the tip of the electrode where we can deliver electrical stimulation replaces the dopamine, and the tremor melts away, the stiffness and slowness melts away, animation of the face returns, walking and coordination all significantly improve to the point where, because we've got, dating back to 1997 with this technology, and in Parkinson's, it's been used since about 2000, 2001. So we have like 20, actually more than 24, almost like 25 to 27 years of experience with it, and long-term data. It keeps working for people for the duration of their disease. It's the one thing that I can almost promise people. I can get them near perfect control of their tremor and usually make them more fluid. At the 6-month mark after deep brain stimulation is implanted and adjusted by a qualified neurology team, and medicines are adjusted, people on average are about 50% better than best medical therapy, right? Best medical therapy is optimizing the meds as best anybody can. And this, people are about 50% better in their overall daily function. And they're on average, anywhere between 30 to 50% less medicine. So these are really important situations when people have refractory symptoms. We're usually, 3, 5, 8, 10 years into the disease and having challenges. Maybe some of the meds are causing confusion. We're getting more sensitive to them as we age, or maybe you have other medical conditions that begin to interfere and cause you to be more sensitive. Similar to how, hey, when we're 25, we can tolerate quite a bit of alcohol, or maybe we take a Benadryl at night to sleep and it doesn't throw us. But once we get to 60, 70 and beyond, we tend to get very sensitive to some of the sedative or confusing effects of medicines. And, it's like you can barely tolerate half a glass of alcohol, sometimes not any, once we get to a certain age. And that's just the reality of how our brains change with age. And we recognize that in neurology. And I'm always trying to spare you the exposure to the meds. And when I can use the clean aspect of this electrical stimulation, I can also adjust it over time. It's not like a light switch. I can actually adjust it like a radio to optimally relieve as much of those physical symptoms of the Parkinson's as possible, as well as decrease the meds and sometimes relieve some of the psychiatric or behavioral or just side effect symptoms that people can get. Okay, so I wanted to make sure I at least made brief mention of that, because that remains a continually evolving technology, and it's light years even from where I started with it back in the early 2000s when this first became available, in terms of what we could do, its lifespan, how long the batteries last, and how quickly we could get to good settings. Okay, so that was deep brain stimulation. And of course, I will answer any other questions people have on any topic, including that at the end. Let's see. Okay, let me take another quick step back. What if you're a person who's joined this talk and you're not sure whether you have Parkinson's or not? Maybe you have tremor, but you're having some issues and you're not sure if it's Parkinson's or a problem like what Katharine Hepburn, the actress from a while ago, she had something called essential tremor, really bad essential tremor. If there's ever a question in your minds, but especially in your neurologist's and your movement disorder team's mind, there's a test called a DAT scan. And so if there's ever a question, or we're not sure, or we're worried about a look-alike disorder, the DAT scan is a study that looks at the amount of dopamine released by your brain. And so we're looking to see if your brain is producing enough of that dopamine deep inside. And so what the test is, it's let me describe it a little bit to you. It's not like an MRI. It's not even like a CAT scan. And it's not noisy at all. It's almost more like a heart study, if any of you have had a nuclear medicine test for a heart study. So here's what it is. Usually you'll go into the imaging center, and there's a few in Orange County. I think there's one at Hoag, there's one in Laguna Hills, there's one at UC Irvine, and I think there's at least one more in the county. And so you'll go in, I don't know, let's say around 10 o'clock, and they'll give you an IV dose of the dye, and then they'll say, bye-bye, go have lunch, and you go off, have lunch, and you come back about 3 hours later. And then they put you under a detector. And so you're kind of sitting under this detector, and all you do is you just kind of sit there. It doesn't make any noise. It's not releasing any radiation or anything. It's just detecting the signal given off by the dye that they gave you 3 hours ago. And what we're looking for is the dopamine part of your brain. Are you producing enough? And there's a number of different disorders that I found this incredibly useful for. I just wanted to make sure everybody knew about it. Does everybody with Parkinson's need it? No. I'm a movement disorder specialist, and really probably 10, at most 20% of my patients do I ever have to order a DAT scan. Most patients, we can make a good clinical diagnosis based on their physical exam features, and then just observe if they respond to carbidopa, levodopa. If they do, you've got your diagnosis. If you're having a hard time tolerating it, there's a funny response, there's other unusual symptoms other than just the classic Parkinson's symptoms, or if you've been on medicines for different psychiatric disorders, sometimes this DAT scan is really, really, really helpful for the neurology team to identify, okay, what are we dealing with? Is it in the Parkinson's family? Is it a lookalike? And so I wanted you all to know, you usually only have to do this once. It doesn't measure like, how bad is your Parkinson's? It just really answers the yes or no. Is it in the Parkinson's family or not? It doesn't even tell us whether it's classic Parkinson's. It tells us whether we're in the Parkinson's family and not like, say, a stroke or a tumor or MS or something else, okay? The other thing we use this for is to help us distinguish if people are having memory problems. And I'm trying to distinguish between something called Alzheimer's and another disorder called Lewy body dementia, kind of a very close cousin of Parkinson's that has a lot of early memory, visual, spatial, and cognitive issues. And this study tells the difference between Alzheimer's and Lewy body dementia. If Alzheimer's is responsible for at least 50 to 60% of all cases of dementia, Lewy body dementia is probably responsible for anywhere between, it's the second most common. So it's like, yeah, what, 15, 20% of cases. And so it kind of looks like a little bit of a combination of Parkinson's and Alzheimer's when you guys look at it from the outside. And this study helps me identify that. So that's the other use of a DAT scan. Okay. All right. Interestingly enough, MRIs can't usually distinguish these disorders real well, right? MRIs are really good at the anatomy of the brain, but this is a functional study. It's kind of like the difference between if you had a heart problem, some types of studies like ultrasounds look and see, hey, is there a valve problem? Is there an anatomic problem of your heart? But an EKG looks at the function of the heart. It looks at the electrical activity of the heart. These are two different things that can go wrong with the heart. Our brain is the same way. We can look at the anatomy and we can look at the function of that in select circumstances. These are the tools that we have that we're grateful to be able to utilize. I wanted to call out other positives that can make a big difference in Parkinson's care in general. And the latest information from the Movement Disorder Society is that the one thing that slows this disease down is physical activity, exercise, and mental stimulation, right? Thus, this is why I come talking for cognitive care solutions, because they really focus on the cognitive stimulation. Do the opposite of what we did during COVID. Don't be in isolation. Don't, limit yourself from activities, stay active and involved, and don't get isolated. So, so there's my cognitive care solutions major plug, but also physical activity and exercise that slows the disease down. Now, if you're a little bit more capable and active, I really am a huge proponent of the different boxing courses. This is an example of one, but I have some this is not the only one in the county. And so this one happens to be up, I think, in in Santa Ana, but there's some other great ones in South County that, and when you're up to that, it's really surprising how much of a difference that has made in my patients. I cannot stress exercise enough. That's why I'm making a big impact at the end. And I think cognitive care solutions would agree with me that physical activity can only be helpful at clearing the cobwebs from our brain, whether that's from the disease of Parkinson's, or whether it's going to slow down the onset of dementia like Alzheimer's, or even dealing with anxiety and depression issues as we cope with this very complex world we all live in. And then, that's really for my more active folks, like the boxing courses, but you could do something like a ballroom dancing course, and I've had some really great responses from that. Or you can go really low key, and we just had recent data on Tai Chi. So Tai Chi is sort of a gentle movement that is sort of a martial art, but it doesn't involve any contact, and it really involves conscious control of your body with gentle movements. Very good for people who have a lot of pain or physical limitations from the Parkinson's or from other orthopedic issues. So that data has been, quite positive, and it's all about keeping the joints active, mobile, and not letting orthopedic problems derail you and causing a setback in multiple areas of your life. Okay. Oh, wait. Oh, I had my ballroom dancing one. I almost forgot about that one. So there we go. Ballroom dancing. And I got some information on the back there. Okay. And then I could keep talking all day about Parkinson's, but now I want to focus on questions from the audience and try to customize this for about the next 15 minutes. To anybody who has questions, I'm happy to answer. So thank you for your patience and listening today. Okay, I got